Well, thank you very much, Stephen. I think after such a busy day with the latest data on treatment and the latest results of the most important study to inform our clinical practice, I would also like to tell you how honored I am to give the last talk. But I would also like to tell you a story, and I hope it will be regarded as a successful story, as you will realize shortly. And it's a story about a country that's not much well known. It's called Tajikistan. And the example of Tajikistan will be used to discuss the use of protease inhibitors, integrase inhibitor, I'm sorry, in developing countries with limited resources, how to use dolutegravir and other integrase inhibitors, which may be the reality where most patients living with HIV are, where there's no genotyping, where resources are scarce, where comorbidity screening and monitoring is still a dream, and what basic tests such as viral load and CD4 count only became available very, very recently. What can we do in such a setting? I hope you will agree that much can be done with dolutegravir and latest integrase inhibitor regimens. So I will very briefly talk about the expansion of integrase inhibitors use in these settings with limited resources. And then I will also comment on the optimization of antiretroviral regimens in Tajikistan with the expansion of dolutegravir use between 2016 and 2022. We've visited the country, we were honored to visit the country 3 times within this time period, and also to show you the impact of these measures with the expansion of dolutegravir use, basic data and clinical indicators of HIV/AIDS in Tajikistan. Good. So everyone remembers the year 2018 when the WHO upon data showing the superiority of dolutegravir-based regimen was so evident that the WHO expanded the recommendation to first-line regimens as well as second-line regimens and in patients who failed non-nuke therapies. Much water has gone under the bridge. 6 years in HIV treatment is a long time, but a very important time, though. And Brazil, as we all know, was one of the countries that led this transition at dolutegravir with this process and one to approve it very quickly. So reviewing, at that time in 2018, the World Health Organization was already recommended the dolutegravir first line for adults and children, left efavirenz as a second option. To children, we still didn't have data of these important studies commented by Professor George. And also considering dolutegravir as second option to patients who failed non-nuke based therapy. The WHO idea was to facilitate access of more individuals living with HIV to treatment. And because they were fixed dose combinations of dolutegravir was also very important. In addition to randomized studies data, were very important to support the recommendation of the World Health Organization. I would also like to mention some data that have been discussed previously. Professor Andrew Phillips of the University College of London holds very important modeling studies to try to find the effect of the introduction of a new treatment, of a new intervention by using different settings or different scenarios. We all know that the model is a rough representation of reality. However, whenever there's no data and to guide recommendations, these modeling studies are very important. And also, these studies can be used to convince policy makers and legislators to implement dolutegravir or any other intervention to all HIV patients. And in this particular case, what he showed very convincingly is that whenever primary or transmitted prevalence to non-nukes were higher than 10%, this is the time when the use of dolutegravir would be most cost effective. Was a very important data. This time, I'm not sure you remember this time when nevirapine was used single dose to decrease the risk of mother-child transmission. As a result, primary resistance to non-nuke was higher, was over 10%, which impacted the use of efavirenz in those times, once again into 2016, as first-line therapy. Because resistance was high, it led many patients to fail efavirenz-based regimens. It was also important by using the mathematical model or modeling, a refined model. He used that dolutegravir used in mating age women would also be cost effective. And they considered the first data from the Simplan study. I believe that in this particular modeling example, he used that somewhat increased the risk associated to dolutegravir. Perhaps if he runs the model again, perhaps it would be even more cost effective with updated date. But that was the context, that was the setting in between 2016, 2017. Those were the data and the recommendations and water modeling studies pointed out too. And then getting back to Tajikistan, first time when I had to go to travel to Tajikistan, I asked, where is it? This country is in Central Asia with 9.1 million inhabitants. The geopolitical importance of the country is huge because if you see it, Russia, Russia, the old Russian emperor was to the south, and the area under the British kingdom was in the south. And here, next to Tajikistan, this was where those three powers overlap. Today it is still very geopolitically important. Most individuals are Muslims, 90+%. The languages are Tajik language is not a Slavic country. It's much closer to Iranian Persia. And of course, Russian is still spoken in medical schools and in higher education in general. And many Tajikistan students will still study in Russia because it's also a regular language. The main industry is aluminium market with 1970s technology as well as cotton plantation. 90% of the country's outcome depend on young men working in Russia and sending it back to their families. Also, it's important to mention that this labor migration is very important in HIV epidemiology in the region. Many will go to Russia to live in large urban centers, and then we have the use of injectable drugs and other risky behaviors, and in some cases when the immigrant comes back with HIV infection. That's a very sensitive issue because in some cases one country is always trying to blame the other. One says that people get infected in different countries, and the other one will, blame the other. I mean, it's just to contextualize. Very important. Tajikistan doesn't have their own resources to purchase antiretroviral. They do not have resources to uh, purchase the necessary tests to manage HIV patient, and it's totally dependent on global fund. That is donations from the global fund to their public HIV care system. And the global fund will only renew the grant after 3 4 years, depending on a report. A report must be put together by experts who visit the country and write a report with the specific recommendations on how to leverage the public health care system in the context of HIV. That was why we visited the country 3 times within this period. These are just a few pictures to illustrate hospitals, drugstores, and the field visits we performed between 2016 to 2022. The methodology includes a document review as well as a review of data and guidelines. This is a very difficult process because we have an important language barrier. There are national guidelines, but they must also be translated to English so that we can actually understand the situation. In addition, when we assess the data are not very consistent many times. Therefore, there is a prior work which is very important to understand the epidemiology situation of the country. We would like to show you this. There is also this meeting with the AIDS advisory group. These colleagues is a very important one. She is the head of the AIDS Republican Center. This is the center responsible for training all infectologists of the country in different regions. The country has a very complex geography. These are very high mountains. So to cross from one mountain to another, it takes you hours and hours. It seems to be close, but you have to go up the mountain, down the mountain, and if there is a snowstorm, there is no transportation whatsoever. Very difficult logistics. Also, meetings with the different partners. This is a context where there are several NGOs. There are many foreign NGOs working in the country because the country is highly dependent on external support and aid. We also visited several AIDS centers, both reference hospitals, but also smaller clinics and hospitals in the countryside of the country to find out how patients were cared for in every region. We also, one of the techniques applied in the missions would be to get in a small hospital, select a patient report and assess that report to check what happened, whether or not there was a missing opportunity. And in the end, we a report is shared with the Ministry of Health and all authorities included in HIV care. And in this report, we try to propose recommendations that are aligned with the latest scientific evidence, but also adjusted to the difficult reality of our colleagues working with the people living with HIV in Tajikistan. So getting back to 2017, what have we found when we were there? First, this chart is just a summary of antiretroviral regimens for adults. There were 11 antiretroviral regimens back then. And some regimens had to include a ritonavir, which needed refrigeration. You wonder, a country with such complex logistics, with such a complex geography, depending on cold chain to move a ritonavir around, having to distribute and organize nationwide 11 different therapeutical regimens. The situation of children, George, I'm not sure George is still here with us. 13 antiretroviral regimens with a variety, a huge difficulty to purchase and to distribute all of these regimens, and greater difficulty to get these regimens to where people living with HIV were. Regarding this cascade, I mean, Mauro doesn't like it much, and I agree with him because this is a rough representation. And when we assess a cascade such as this, a continuum of care, the analysis should include more details in what data shows. But to visit a country and have a snapshot access or assessment is very useful. We had 16,000 individuals with HIV. Only 8,000 were diagnosed. 54% of people living with HIV didn't even know about the diagnosis. Of those diagnosed, only 46% were on antiretroviral therapy. And of the 4,000 patients, only 1,000 had a viral load test. The viral load was only available in the capital city in 2 or 3 major cities, and the other patients had no viral load assessment. Of those with a viral load, only 75% had indetectable viral load. That's the situation. But let us check the indicators. But before we get to indicators, just as a summary of this situation we found in 2017, there was a lot of emphasis on visits to experts. The patient would have to have several CD4 before beginning treatment, before start study data. When treatment started to be recommended, regardless of CD4, most patients on on efavirenz with tenofovir, many patients on concidofovir-based treatment, toxical facial lipotrophia, stigma, many patients on nevirapine, and also many women getting caletra. I'm not sure you remember this time where there was a risk. People were afraid of efavirenz in pregnancy, just like dolutegravir, and then they started to do caletra a lot. We saw this in Tajikistan. Everyone said that there were side effects, but when we checked the data, there was no side effects whatsoever. Regarding primary transmitted resistance, we were already aware. I mean, this is the only data we had in Tajikistan. This was an observational transversal study, a Russian study with a very difficult and not reliable study showing already 10%. The dolutegravir in first line with 10% resistance. The data in terms of the number of cases were growing, including among those who declared heterosexual. Those curves left the WHO very concerned. It was the worst in all Central Asian countries. But when we observe only those cases diagnosed with AIDS, opportunistic disease, and CD4 count under 200, as well as AIDS-related deaths, with an increasing trend, very concerning, therefore. So, we recommended the expansion of dolutegravir, and we back to the country again in August last year, and in November to assess the situation. Then we already had only 7 antiretroviral regimens for adults. So the doctors did a great job, and it was one of the countries where this transition to dolutegravir in adults was very successful. But in children, still with 11 different antiretroviral regimens. Back then, the country had already 9,000 adult cases of HIV and 300 children diagnosed with HIV. The continuum of care had already improved a lot. You see that 76% of the estimated population had already been diagnosed with HIV. 85% of those getting antiretroviral therapy, I mean, those that were registered in the system were receiving antiretroviral therapy, and of those getting retroviral therapy, 88% were suppressed. So much better than from when we saw it the first time. But what was the impact of this implementation in absolute data? This is just a summary. Most patients were already on dolutegravir. Some women, most patients on F5 were women, still fearing CEPAN study data. Very few individuals on natazanavir, especially the patients, epileptic patients and patients on carbamazepine, and Caletra had been replaced in a few cases by atazanavir. Viral load was already available in most of the country, and it helped the control and management of the patients, but with no strategy to monitor side effects and therapeutical switches. And see the result? Mauro, very similar to your Australian and Singapore curve when PrEP was introduction. In this case, the difference when the number of new cases started to decrease, that was a consequence of dolutegravir use expansion. Very important decrease in the number of AIDS cases, and but children is still with 11 different regimens. This is the time when Odyssey and other studies were published. Then only to remind us, this was a study that helped us with recommendations, showing that dolutegravir, in the same way that it was expanded successfully among adults, it could also be successfully expanded in children under 14 kilograms and above 3 kilograms. Together with this, the World Health Organization recommended the use of dolutegravir 5 and 10 milligrams. The country didn't still have the 5 milligram dolutegravir, but already have the 10 milligram dolutegravir. And what we recommended was the monitoring of side effects. We still don't know what happens in terms of renal toxicity. For instance, some patients are not tested for creatinine as well as weight gain. I myself, I'm not sure this is something they should be concerned with in face of so many problems, but that's the recommendation of WHO. We recommended a plan to optimize dolutegravir to children, to neonates, like George also said, and given the high resistance data to nevirapine, a feasible option was raltegravir. It seems that the country was also in the process of buying sequencing devices, but they could not do sequencing and genotyping to every patient. So we recommended prioritizing patients who had been exposed to multiple treatments, particularly those who had been treated with protease inhibitor in the past, as the priority for sequencing and genotyping. This is just to close this story. I think it's a successful story. The expansion of dolutegravir use in the real world. And I would also like to say that these positive results would never be seen if it were not for the professionals of care in Tajikistan. It's one of the most hospitable countries I've ever visited, and my infectology colleagues doing as much as they could in face of very difficult circumstances, fighting for their patients. So a great example of dedication. So these are my acknowledgements. Thank you too.